Hello. Um, Before I start anything, let me go ahead and make sure that my audio works on my phone because I've had an audio issue before and I'm not gonna have one right now. Okay, so my audio works, but if we can hear the water dripping, so I'll fix that right now. Hopefully. I guess. Okay. So this is going to be for anatomy. We're studying the urinary system and the endocrine system. And I'm going to get ready while we do this. Okay. So first we're going to talk about the urinary system. So the broad blood path. The water is still dripping. Okay, anyways. The broad blood path is basically from the renal artery to the renal vein, or the renal artery, then it'll become filtrate. It'll come filtered into the filtrate and then reabsorbed to the renal vein, or it will be from the renal artery to the filtrate to the urine. So it could either go straight from the renal artery to the renal vein, or it could be filtered and reabsorbed, or it could be filtered and then excreted. So that's the three paths. The broad filtrate path is from the nephron to the minor calyx to the major calyx to the renal pelvis, the bladder, then the urethra. And the functions of urinary system is basically it can manage the pH by the H ion, hydrogen ion concentration, and then bicarbonate concentration. So basically via secretion and reabsorption of those two ions. It can also regulate blood pressure by water and renin. So it will secrete renin and then reabsorb water. And then it can manage blood osmolality and ion balance by sodium, potassium, and chloride secretion and absorption. It can eliminate waste by urea secretion, and then eliminate extra sodium and toxins. It can conserve glucose and amino acid, and it can secrete hormones like renin to regulate blood pressure and erythropoietin for red blood cell production. And then it can metabolize vitamin D to its active form. Okay, so the anatomy of the kidney, you have the renal capsule, which is the outside, then the cortex, then the medulla. Renal pyramids are in the medulla and drain urine from the nephrons, and they're separated by columns. The renal calyces drain urine from the pyramids, so you have the major calyx, which drains from the pyramid, then the minor calyx, which drains from the major. Then you have the renal pelvis, which drains the urine from the calyces, then the ureter takes the urine from the kidneys to the urinary bladder. The renal hilum contains the renal artery and the vein, the ureter, nerves, and lymph tissues. The renal artery supplies oxygenated blood to the kidney to be filtered, and then the renal vein returns reabsorbed nutrients and ions back to the body. Okay, so this is the detailed blood path. It'll come from the renal artery to the segmental arterial, interlobar arterial, arterial, interlobular arterial, afferent arterial, glomerulus, efferent arterioles, then the peritubular capillaries or the vasa recta. So the peritubular capillaries are above, they're in the cortex, and then the vasa recta is in the medulla. And then it'll go to the interlobular vein, arcuate vein, interlobar vein, and then finally the renal vein. the detailed filtrate path. So you have the Bowman's capsule, proximal convoluted tubule, descending loop of Henle, ascending loop of Henle, distal convoluted tubule, collecting duct, then the minor calyx, major calyx, vena pelvis, ureter, bladder, then urethra, where it goes out. So nephrons, there's two types. So there are cortical nephrons, which are in the cortex, and it has a short loop of Henle. It doesn't go deep into the medulla, like the loop of Henle doesn't dip deep into the medulla, whereas the juxtamedullary is long and it goes deep into the medulla, and it has a high osmolarity gradient. There's two types of capillaries. The peritubular capillaries are around the proximal and distal tubules at cortical nephrons. So again, up in the cortex, and then the peritubular capillaries, or the vasa recta, is in the deep medulla and at the juxtamedullary nephrons, and it helps form the concentrated urine. Okay, so the physiology of the nephron. So basically, 100% oxygenated blood will go in through that renal vein. So 80% of that will not be reabsorbed and it'll just go straight to the renal vein. Whereas 20% is filtered at the glomerulus, or like from the glomerulus to the filtrate. 99% of that filtrate will eventually be reabsorbed, whereas a small amount is going to be secreted, and then also the secreted amount plus the amount that isn't reabsorbed will be excreted into the urine. The Bowman's capsule has leaky epithelial and basement membrane cells. So they're called podocytes, and they allow they allow sodium and glucose, but not white blood cells and proteins into like filtration, because they could injure the glomerular capillaries. Okay, so at the Bowman's capsule, you have filtration of 20% blood. So it'll filter water, bicarbonate, the 3 ions, urea, amino acids, and creatinine. And then at the PCT, you have reabsorption of water, bicarbonate, the ions, glucose, amino acids, and it'll go to the peritubular capillary. So basically everything except for urea and creatinine. And then it'll also, at the PCT, the capillaries will secrete hydrogen ion and some drugs into the PCT. At the loop of Henle, you have reabsorption. So the descending loop of Henle, only water will be reabsorbed to the vasa recta. And then for the ascending loop of Henle, only ions will be reabsorbed. For the DCT, water, bicarbonate, and then Na and Cl are reabsorbed to the peritubular capillaries. And also at the DCT, there's secretion of hydrogen and potassium from the interstitial fluid to the DCT. Now for the collecting duct, so there's water, urea, and salt reabsorption. And then for the last two, so like the only place that filters is the Bowman's capsule. PTT, there's main reabsorption, and LOH is also main reabsorption, whereas DCT and collecting duct are like fine filtration, fine tuning. Okay, so we're gonna talk about the filtration rate. The filtration rate is the volume of filtrate formed per minute. So it depends on the net filtration pressure. And the normal one is 125 milliliters per minute. It'll be affected by the hydrostatic pressure in the glomerulus, which is usually 55 mmHg. It's the force exerted by the blood pressure that pushes blood out of the glomerulus and favors GFR. It'll depend on the afferent and efferent arterial diameter, and usually the afferent diameter is higher than the efferent. Next, you have the hydrostatic pressure in the Bowman's capsule. Give me a second. That's the force exerted by filtrate that's already present in the Bowman's capsule, then that hinders the rate of the filtration of more fluid trying to enter it, so it'll oppose GFR because it's trying to like prevent more fluid going into that, more fluid being filtered. Now the osmotic pressure in the blood plasma, which is usually 30, so it'll be 50. Sorry. Force exerted by the proteins or albumin that pulls water back into the bloodstream and hinders fluid entering the Bowman's capsule. This also opposes filtration. So yeah. So the net filtration pressure will be the hydrostatic pressure in the glomerulus, minus the OPGC, the osmotic pressure, and the blood plasma. And then it'll also be minus the hydrostatic pressure in the Bowman's capsule. So with more proteins, the OPGC decreases, and then with the afferent arterial diameter increasing, then GFR will also increase. So the positive NFP will favor filtration, and the negative NFP will oppose filtration. For that formula that I just gave, the average values of all of those will be 55 minus 30 minus 15. So a negative, like a normal NFP is positive 10 mmHg. GFR can also be measured by doing a KF, which is a filtration coefficient determined by the glomerular surface area multiplied by the NFP. So a higher KF and a higher NFP will equal a higher GFR. Okay, so the glomerular filtration rate intrinsic control or auto-regulation. This goal is to maintain the glomerular filtration rate. So the juxtaglomerular apparatus is the area of the arterioles at the Bowman capsule opening. It'll regulate the blood pressure by vasoconstriction or dilation of the efferent or afferent arterioles. The macular cells will detect the salt concentration, and granular cells will detect the afferent arterial pressure. The myogenic mechanism, so basically the afferent arteriole will vasoconstrict to lower the GFR when there's high blood flow, and vice versa. So it'll vasodilate to raise GFR when there's low blood flow. The tuboglomerular feedback mechanism, so the afferent arteriole will vasoconstrict to lower GFR when there's a high salt concentration in the filtrate or fast movement, and vice versa. So both of these stimuli, so like there's like a high flow and then high salt in that filtrate, and high blood pressure will trigger both of these mechanisms. Okay, so there is also, in addition to intrinsic control, you have extrinsic control. So when there's low blood pressure, so this is the intrinsic control is to maintain the GFR. The extrinsic control is to maintain the systemic blood pressure, even if it hurts the kidneys. So when there's low blood pressure, the kidneys will start to secrete renin. This will lead to angiotensin 1 and 2, and then raises ADH aldosterone, and then will also cause vasoconstriction, which will also raise the sodium and water reabsorption, which then raises the blood pressure. And then also epinephrine and norepinephrine will raise the heart rate and blood pressure. When there's high blood pressure, then ANP will be secreted, which will lower renin, angiotensin, ADH, aldosterone, and also vasodilate. And it will promote water and sodium excretion instead of reabsorption. And then this will lower the blood pressure. And then also ACH will lower the heart rate, which will then lower the blood pressure. Angiotensin 2 basically increases thirst, blood volume, vasoconstriction, and ADH secretion, from the posterior pituitary, and then aldosterone secretion from the adrenal gland. And then atrial natriuretic peptide, which is ANP, is secreted by or released by the atria when there's a high blood volume, and it'll like stretch them. So high blood volume means high ANP. So yeah. So the mean arterial pressure, so when it's under 80, it'll be under extrinsic control, and your body will try to like secrete renin and then do that whole renin angiotensin pathway to increase your blood pressure. Now, if it's between 80 and 180, it'll be like under intrinsic control, so like auto-regulation of the myogenic and tuboglomerular response pathway. So when it's closer to 80, the afferent diameter will increase, and then when it's closer to 180, the afferent diameter will decrease. Now, if it's above 180, it'll be under extrinsic control again. So this means like the body will try to increase the amount of ANP, or like ANP will be released from the heart, and then that will decrease renin and everything else. Okay, so we're going to talk about reabsorption now. So reabsorption can be occurred by pumping the sodium against its gradient, or also using the gradient. So there's three places we're going to be talking about: the proximal convoluted tubule, the loop of Henle, and then distal convoluted tubule. So at the proximal convoluted tubule, so I guess first we're going to talk about what can go out of that cell, so out of the PCT. So actually we'll talk first about diffusion, I guess. Diffusion at PCT, so water can go through by the aquaporins on the cell and then reabsorb into that peritubular capillary. And then Cl, chlorine, calcium, and potassium can go through the paracellular route, so in between cells. And then glucose and amino acids can go in with the NAK-ATPase, I guess. Or no, the NA co-transporter. It'll go in the cell, and then it can go out through the basolateral side. So glucose, amino acid, and other ions. Okay, so secondary active transport, you have that Na plus co-transporter. It'll use the energy to move sodium down the gradient. Sorry. And then, sorry. Okay, active transport. So the Na slash K ATPase, so that will help pump Na out of the cell and pump potassium into that cell, basically. Now the NaH ATPase will pump hydrogen ion out of the cell and also sodium out of the cell, but not for reabsorption. It'll secrete. It'll be in charge of secretion. Now the Na plus HCO3 ATPase will pump bicarbonate and Na out of that cell for reabsorption. So basically all that is being secreted is sodium and hydrogen ion into the proximal convoluted tubule, and then or out of the proximal convoluted tubule into the like water or whatever, or the filtrate. And then what is reabsorbed is glucose, amino acids, ions, water, and bicarbonate. At the loop of Henle, you have, for the descending limb, water will be reabsorbed to the vasa recta via those aquaporins again, that's diffusion. Now for the ascending limb cells, you only have Na plus, Cl minus, or Cl minus, and K. So how these are reabsorbed, I guess, they'll go through that Na plus co-transporter. And then it'll go into the tubule by that pathway. And then Na and K pumped into and out of the cell via that NAK ATPase. And then Cl and K will also just reabsorb through that basolateral side without needing to use pretty much anything. Basically, in the lumen of these these cells, there's high sodium and low glucose, whereas in the cell there's low sodium. Okay, at the distal convoluted tubule, you have water going through that aquaporins for reabsorption, and then you also have Na and Cl going into the cell via that Na plus cotransporter, and then Na and K will move into or out of the cell through that peritubular capillary via the NAK ATPase. So I think basically what is reabsorbed is Na and water, pretty much. Yeah, Na and water. The distal tubule and the collecting duct are both under aldosterone hormone control for sodium reabsorption. So aldosterone release is caused by low blood pressure. So if there's aldosterone, the blood pressure will raise. Now, blood plasma sodium will also cause reabsorption, and then high plasma potassium will also cause aldosterone release. High aldosterone will mean high reabsorption and high potassium secretion. Now, the limit of reabsorption. So basically, the limit is like there's only so much reabsorption that can happen based on the amount of proteins present. The amount of proteins is irrelevant, but you just need to know that like reabsorption is usually like always like limited to a certain like point. So there's 2 points you need to know. The transport maximum is the max amount of solute that can be transported by the renal tubule. So basically what it means is like the transport maximum is the maximum amount of like filtrate or like anything that can be held by a tubule. So the maximum amount of reabsorption or the maximum amount of secretion, basically. Now the renal threshold is the plasma concentration at which a substance appears in urine. So that's basically where excretion will start happening. So filtration will always happen. It'll go straight up. And then reabsorption will follow filtration until it reaches that transport maximum, and then it's just going to plateau. It's not going to change. It's just going to stay there. And then excretion's line going up will start at that renal threshold. So there's 0% excretion below the renal threshold, and then you only have to calculate the rate of filtration when the substrate concentration is below the renal threshold, because if it's above the renal threshold, then if it's above the renal threshold, that's basically above like the transport maximum. That means the reabsorption will just always equal the transport maximum. So the filtration rate is the GFR multiplied by the concentration of the substrate or like the substance. So the countercurrent multiplier. Osmolarity is the measure of solute concentration. So something can be either isomodic, hypoosmotic, or hyperosmotic. The countercurrent multiplier is the fluid flowing opposite direction and parallel and adjacent tubes. The mechanism establishes a salt current using countercurrent multiplier. It'll use the energy to create the osmotic gradient. And then also the countercurrent exchanger will maintain that osmotic gradient. So it is either the multiplier creating it and the exchanger maintaining it. So the location of this is the loop of Henle and vasa recta. So it'll be the ascending LOH and the descending LOH, the ascending VR and the descending VR, descending LOH and the ascending VR, and then ascending LOH and descending VR. Well, all of these will do that. So the loop of Henle will cross the cortex medulla border. The descending LOH will be water permeable and salt impermeable. The water will leave to the vasa recta, and then the osmosis will increase as the filtrate moves down the LOH. Now the ascending LOH will be water impermeable and pumps out NaCl and K, which will make the medulla salty. The osmolarity will decrease as the filtrate moves up the LOH. So both of these will equal the countercurrent multiplier because the LOH will pump ions into the medulla without water. So this will decrease the osmolarity, and then it'll become a hypoosmotic by the time the filtrate leaves the LOH. So the filtrate will be hypoosmotic to like basically the medulla. The vasa recta is a capillary that surrounds the LOH. It's permeable to water and solutes. The descending VR is mostly permeable to solutes, so like NaCl and K. The ascending VR is usually like water reabsorption, and this maintains the osmolarity gradient in the medulla. So at the Bowman's capsule, the osmolarity is basically 300, and then it's 300 at the proximal convoluted tubule. As it moves down, it goes 400, 600, 900, and then on the bottom it's 1,200. Then as it goes up, it's 700, 400, 200, 100. It's variable at the DCT, and then at the collecting duct, it can be either 1,200 with ADH, or if you don't have ADH, then it'll probably just be like 100. So the osmolarity of the interstitial fluid, it's usually 400, where the loop starts, and then down more it's 600, and then down more it's 1,200. Now at the vasa recta, if it's straight, it goes 400, 600, 900, 1,000. So it follows the osmolarity of the descending loop. But if the vasa recta is like in a hairpin loop formation, then it'll go 400, 600, 900, 1,000, 700, 400, and then 200. So basically it'll follow like both of the loops. So that's like a more maintained osmolarity. Again, the collecting duct is under ADH control from the posterior pituitary gland. More ADH will mean more aquaporins on the collecting duct, which means more water reabsorption. And then it'll also mean more osmolarity as the filtrate will move down the collecting duct. But so it'll result in like higher concentrated urine by the time it reaches like excretion, basically. Diabetes insipidus. So it can either be neurogenic, which means you have insufficient ADH, or nephrogenic, which means ADH insensitivity. And then you have diabetes mellitus. So that's type 1, which is either insufficient insulin, or type 2, which is insulin insensitivity. For diabetes patients, not all glucose is absorbed at the proximal convoluted tubule, so it will end up excreted in the urine. So that's interesting to know. Okay, now we're going to talk about the endocrine system. Endocrine components, it can function for homeostasis, metabolism, growth, sexual reproduction like gametogenesis, coitus, fertilization, and fetal growth and nourishment. Homeostasis, management differences. So the nervous system is actually short-term management via neurotransmitter and receptors. It's localized, fast, but short-acting. Whereas the endocrine system is long-term regulation by hormones and receptors. It's systemic and takes minutes to hours long. And then types of glands, you have exocrine glands, which excrete non-hormonal products to a membrane and has ducts, whereas endocrine glands secrete hormones to the bloodstream and are ductless. Hormone release is usually controlled by negative feedback when the hormone feeds back to inhibit its own secretion. Okay, so now we're going to talk about the glands. So the hypothalamus produces ADH, oxytocin, and regulatory hormones. The pituitary, so you have the posterior pituitary. So you have that ADH and oxytocin secretion from there. And then okay, sorry. Okay, yeah, and the anterior pituitary will have luteinizing hormone, which is LH, FSH, ACTH, TSH, and HGH production. The pineal gland produces melatonin. The thyroid gland produces thyroxine and triiodothyroxine, which is T4 and T5. Parathyroid produces PTH. Heart produces atrial natriuretic peptide. The the digestive system, which is gastrin, somatostatin, and etc. The pancreas secretes insulin and glucagon. The kidney secretes erythropoietin. The adrenal, so the cortex will secrete the cortisol and the aldosterone, whereas the medulla will secrete the epinephrine and norepinephrine. The adipose tissue will secrete leptin, and then the gonads, so the testes will secrete androgen and inhibin, and then ovaries will secrete estrogen and progesterone, as well as inhibin as well. Types of hormones, so you have amino acid derivatives, which are like epinephrine and thyroid hormones, and then you have peptide derivatives, which are like TRH, ADH, FSH, oxytocin, and LH. So both amino acid and peptide derivatives, except for thyroid hormones, are water soluble. They can't cross the cell membrane, and then they can only bind to membrane receptors, which will activate secondary messengers like CAMP to activate or inactivate an enzyme. Now, lipid derivatives like estrogen and testosterone, including thyroid hormones, which are amino acid derivatives, can cross the cell membrane. They bind to binding proteins and then intracellular or thyroid hormone receptors. So the hormone receptor complex will enter the nucleus, bind to DNA, and start/stop the protein production. Hormone action will depend on blood levels, which means like rate of hormone synthesis, levels of binding proteins, and then also clearance rate. It'll also be dependent on the amount of receptors present on target cells. So more hormone action will decrease the sorry. Let me look at upregulation. Okay, so if there's more hormone action, it'll decrease the amount of receptors. So that's downregulation. And then if there's not a lot of hormone action, the cell will increase the amount of receptors, which means upregulation. So it'll like be more sensitive to that hormone since there isn't a lot of it. And then receptor affinity for the hormone also relates to how well a hormone works. Okay, and then alpha fetoprotein will protect a fetus from high levels of estrogen in a pregnant mother's body by binding to estrogen and preventing it from crossing the placenta barrier into the brain. Okay, first I want to talk about the hypothalamus pituitary axis. So the hypothalamus will produce ADH, oxytocin, and regulatory hormones. The ADH and oxytocin will move to the posterior pituitary by extended hypothalamic neurons, whereas the regulatory hormones will move to the anterior pituitary by the hypophyseal system, which means it'll go to the capillary bed, then the vein, then the capillary bed to regulate the hormones it secretes. Hormones the pituitary secretes. Okay, so the posterior pituitary will secrete ADH and oxytocin. The target cells are ADH2 kidney for the insertion of aquaporins for reabsorption. And then oxytocin will move to the mammary gland or the uterus for milk or contractions. The anterior pituitary will produce various hormones, and the secretion is regulated by the hypothalamus. So first you got the prolactin to the mammary gland for milk, the growth hormone to the bones for growth, LH and FSH to gonads for steroid synthesis and gametogenesis. You have thyroid stimulating hormone to the thyroid for production of T3 and T4. Adrenotropic hormone, ACTH, to adrenal gland for cortisol, aldosterone, and androgen production. Physical, physiological, and psychological stress responses. So, first, you have that acute stress response by hormones, and this will relate with epinephrine, norepinephrine. The brain will send the signal down the spinal cord. And then the sympathetic nerves will stimulate the adrenal medulla to secrete epi. The epi will trigger the fight or fight response, will raise HRBP, bronchodilation, constrict some blood vessels but dilate skeletal and heart vessels, and then decrease digestive and urinary. Long-term stress response. So basically, the hypothalamus will secrete a corticotropin releasing hormone, which is CRH. The CRH will stimulate the anterior pituitary to secrete ACTH and beta endorphins. So basically, the anterior pituitary will secrete pro-opiomelanocortin, which is POMC. It's an amino acid complex that includes beta endorphins and ACTH. Both of these will travel to that adrenal cortex by blood, and then this will stimulate secretion of cortisol, aldosterone, and androgen. So basically, so the cortex layers have different hormones. So the zona glomerulosa will secrete mineralocorticoids. So these are adrenocorticotropic hormones. So aldosterone will increase that reabsorption and secretion. Now, zona fasciculata will secrete glucocorticoids, which is like cortisol. Zona reticularis will secrete androgens. It doesn't have a stress role, but it has a sexual role. And then the medulla of the adrenal gland will secrete the epi and norepi. So cortisol's role in stress, it'll increase glycogen synthesis and gluconeogenesis, which will lead to hyperglycemia. It'll cause protein breakdown, so it'll make glucose from amino acid and glycerol. Also leads to hyperglycemia. It'll resist insulin, suppress the immune system, suppress the reproductive system, and cause fat deposition around the abdomen and raise blood pressure. Okay, now the thyroid. The thyroid gland is on the trachea. It has the blood supplied by the inferior and superior thyroid arteries. The follicular cells will produce that thyroxine and triiodothyroxine, which is T3 and T4. Thyroid hormone is our body's major metabolic hormone. It affects everything but the adult brain, spleen, testis, uterus, and thyroid gland. So the functions, it'll increase the metabolic rate, mobilize fats, increase glucose absorption in the gut, raise BMR, body heat, and oxygen consumption, raise adrenogenic receptor in vessels, cardiac muscles, so epi sensitivity and heart rate response and respiratory. It will have it'll help development, so like protein synthesis. Too much TH will also have the opposite effect. It'll break down glycogen into glucose. It'll also promote normal female reproductive fertility and ability. So production, so the thyrotropin releasing hormone, TRH, will lead to TSH from the anterior pituitary, and the thyroid follicular cells will synthesize thyroglobulin, which will secrete into the colloid. Then when you ingest iodide, it'll be trapped into the follicular cells and then go to the colloid. Iodide is then oxidized into iodine and then added to thyroglobulin to make T3 and T4. So the thyroglobulin is taken up by a cell via endocytosis and fused with a vesicle. The lysosome will cleave T3 and T4 from the thyroglobulin. Then the free T3 and T4 is secreted into the bloodstream and will bind a protein for transport. There is usually more T4 than T3 in the blood because T3 is more potent, and at the right time, T4 will convert to T3 and bind to intracellular receptors. Okay, now the pancreas. Insulin is secreted by beta pancreas cells in response to high blood glucose. It'll turn glucose into glycogen for liver storage. It'll increase glucose uptake by most cells by inserting a glucose transporter. Target cells are liver cells and most cells in the body, and then negative feedback after that. Then glucagon is secreted by alpha cells in response to low blood glucose, does this opposite thing, turns glycogen into glucose, which is glycogenolysis. And then target cells are liver cells, and then again, negative feedback after everything is pretty much set. Pathology, an abnormal hormone level can be caused by failure of feedback systems, loss of endocrine cells. For example, diabetes mellitus type 1 will have the beta cells destroyed, which means low insulin. Overproduction of hormones due to tumor or ectopic related sources. Now, failure of target cells responding to hormones due to decreased amount receptors, receptor disorder, or inadequate synthesis of second messengers or membrane receptors, or impaired immune function, for example, type 2 diabetes mellitus, will also cause an abnormal hormone level. Hypercortisolism, or Cushing syndromes, or natriogenic Cushing's due to cortisol therapy. The cause can be an adrenal tumor, which will increase the amount of cortisol, the pituitary tumor, which will increase the amount of ACTH, or cortisol therapy, because there's high amounts of cortisol. This will increase the amount of glucose in your body. You'll have less muscles, fat redistributes to the abdomen, and then poor wound healing. Hypocortisolism is an Addison's disease. The cause is autoimmune destruction of the adrenal cortex. So there's a lower cortisol, aldosterone, and androgens. Symptoms is lowered sodium reabsorption, so low plasma sodium and glucose, and then lower potassium secretion, so high plasma K plus, and then lower water reabsorption, so dehydration and hypotension. Hyperthyroidism is Graves' disease. So this is an autoimmune production of TSH mimicking antibody. So this will increase pretty much like the thyroid hormones, whereas TRH or whatever, TSH and TRH will be decreased due to like that negative feedback. The more there is of a certain hormone, the less there is of a certain pre-hormone, I guess. The symptoms of hypothyroid or hyperthyroidism is increased BMR, heat, HR reflexes, lowered strength and weight, insomnia, and restlessness. Hypothyroidism is myxedema caused by thyroid removal or lack of iodine in diet. Symptoms will be cold, lowered BMR, HR reflexes, speech, thought process, and also enlarged thyroid gland from lower T3 and T4, however, higher TSH or colloid. Chronic stress can lead to diabetes, hypertension, infertility, and disease risk. That's basically it. Bye.